I'll speak to the iron. There's one study where they started iron supplements at 2 milligrams per kilogram at 2 weeks, and in another group in that same study at 4 weeks. And when they started at 4 weeks, there were more deficient babies later on. Therefore, I recommend starting iron for supplementation at 2 weeks at a dose of 2 milligrams per kilogram. Total dose. Now, if you have, baby should be fed formula, then that provides most of that iron. If the baby receives human milk without fortifier, then the baby needs 2 milligrams. If the baby receives human milk with a fortifier, that usually provides enough iron. So the total iron supplementation should be 2 milligrams starting at 2 per kilogram, starting at 2.
We start the iron supplement when they get to full oral feedings, unless they've had a transfusion. Do you have rules about transfusions? However, you can't get it for a month after you've had a transfusion of blood, which gives considerable iron load.
Transfusion provides a large amount of iron. One transfusion is equivalent to 14 milligrams of iron. And that's why if you look at...
It's all absorbed.
It's all in, yes. If you look at ferritin levels in premature babies who have received transfusions, they're very, very high. But once these babies grow, they rapidly use up that iron. So you cannot rely on that. That's why we give iron soon, even if they have transfusions.
There is a special condition of ABO incompatibility or RH incompatibility at birth, even not preterm. And this kind of baby is hemolyzing too much. And after 2 months, you will find that he's left with late anemia. So this should be given iron again early. It's not like the usual one you are giving after 4 months or after 6 months, but it should be after 2 months. This is totally different. It's not because you are seeing patients in the NICU and then after they come back with late anemia. So you have to give iron early. We have 2 questions left. Professor Hodwood. I'm sorry, they are telling me that we are running very rapid, short of time, and we have to conclude in just 2 questions. Yes.
Thank you, Professor Zegler, for your fascinating talks. I'm Mustafa, gastroenterologist. I'm not wondering that you were shocked by the results of Krebs about cereal versus meat, because I think this study is full of bias. Number one, what type of beef meat was given? Was the age different or not? And what type of cooking or purification or emulsification was used? And is this digestible or not? And the plant mixture used was not actually cereal. It contained soya, and soya is high biological value protein. So I think the conclusion of this work, what's your opinion? Will not give what we want or what we expect or what can shock us. Thank you.
He says it's working. My conclusion was that there was, whatever it was, there was no improvement of the stunting. There was no improvement of the stunting, which I don't understand. I don't know either the other factors that led to stunting, such as recurrent infections, diarrhea, were more powerful, but I don't think we should discount it and just say that the meat was probably not absorbed or something. It somehow didn't work. I don't know why.
Perhaps the taste.
Was there questions?
Yeah, here is a question.
I'd like to thank all the speakers. I have 2 questions. One is, if you say that vitamin D is not the right test for rickets, what do you advise? Do you do calcium, phosphorus, alkaline phosphatase?
X-ray's the best.
X-rays, clinical,
X-ray is the best.
My other question is, as a prevention of vitamin D deficiency, as a treatment,
if you have a baby or a child who you think has rickets, and you get an X-ray and that baby has rickets, treat with vitamin D regardless of what the 20 milligrams
as a treatment or as a prevention for vitamin D deficiency, would which one do you recommend? Vitamin D2, 3, 1 alpha?
Well,
What is your
in our
recommendation?
country, it's hard to get anything but D3 now. It's replaced D2.
Is 1 alpha suitable?
Pardon?
Is 1 alpha?
One hydroxychloroquine.
Oh, yeah, you could potentially use that.
That's
yes.
normally used in renal disease, but as a prevention, is it acceptable?
It's not used for prevention or treatment that I know of. Unless, like you said, you're a nephrologist and you're a kidney doctor, you know, they use that kind of thing. But no, we don't use it.
Any time for other questions, or it's okay? I'm sorry, this is.
Thank you everyone. We can have a lot of discussion over lunch.
You mentioned you are very busy, but I feel whatever you are busy, we need to give time for 2 items at the history: nutritional history and social history. Because I attended one course with WHO regarding complementary feeding. Really, after I finished the 3 days, I feel I have defected in my knowledge regarding the feeding. Just to prescribe to the mother by the age of 6 months, go and give your baby meat, go and give your baby egg. But details of preparation, I feel it's our responsibility. Because a lot of myth in the community, so who will tell, supposed to be by our hand. So I think you must give time to social history and the nutritional history.
Thank you. This is very important comment. Thank you. Another question there? Yes. You have commented for Professor David?
Okay, sorry, do you have a comment?
Just a question. Actually, it's not a question, rather than the way we are starting weaning. Beforehand, we started by juice, and some of you by cereals. And there was a great debate about using vegetables in the start. It was a big conference, and in this conference, they just only take this as, do you start by vegetables or you start by fruits? And finally, they decided to start by vegetables. So in a way, we have to change our way of weaning from this conference, when, what, and the idea. So this is very important to get as a point, what is the idea? Not with the cereal, not with the juice, not with orange, not with apple, like most of us were doing before, but with vegetables. It's a very small point to make it, but we have to be sure that we are changing all the time, and this is the best now. To start from 6 months, to start by vegetables, to start slowly but surely until you get the end of the week.
Thank you, Professor David. The question there, please.
Yes.
Introduce yourself, please.
Yes, Dr. Judy from Lebanon, Hamad Hospital, Saida. What got my attention is when we start reading, you said we switch immediately to iron-rich food, like meats and others. And this is contradictory to what we know about introduction of food other than milk. Usually starts with a little bit of carbohydrates, vegetables or fruits, and usually at 9 months we start feeding the infant meat. That's why we give supplements of iron at an earlier age, for example 6 or 7 months. So this has changed within the last 2 or 3 years?
Dr. Green will answer you.
Is this working? Yes.
Yes.
Well, that's a very interesting question, and I think Dr. Ziegler addressed that a little bit yesterday. But the truth of the matter is, we've had complementary fooding on for somewhere between 10,000 and 20,000 years. 10 to 20,000 years. If you go back 15,000 years ago, when we were hunter-gatherers, you can do the math, and it's amazing what the iron intake would have been in a newborn infant during the era of hunter-gatherers, before we became agriculturally based. Now, if you do the math, we fed far more iron 10,000, 20,000 years ago than we do today. Now, having said that, you talked about 3 levels of evidence, A, B, and C. We, at the Academy, we speak of 4 levels of evidence, not just 3. And we say that guidelines should be transparent, all right? Transparency means you should be able to categorize the evidence behind the guideline. It must be transparent. It's called a transparency statement, which is now at the end of all the academy guidelines. But we have the same levels A, B, and C, but we also have a fourth level, which is called expert opinion. Expert opinion, which is the worst level of evidence. But the truth of the matter is, you can't get away from expert opinion. Right? We have to acknowledge that. And when it comes to iron, I think Eggert yesterday reviewed some of the evidence, the Nancy Krebs study, and some of the early studies that have been done in the last 10 years. There's not a lot of evidence that meat, randomized controlled trial, is a good source of iron. Yet we all know and believe it is. So I really can't answer your question other than it's probably somewhat based on expert opinion. And that we have been doing it wrong for a long time now. And as people just decided on vegetables and fruit. There was no evidence whatsoever to support that. And the reason in our country we started using rice cereal in the 1970s instead of other grain cereals was because of the fear of allergies. Okay, so sometime in the 1970s, the first complementary food in the United States became rice cereal, which is almost worthless as a nutrient. Sometimes it's fortified with iron, but it's not a very good source of most nutrients. So I know in Germany, for instance, they have historically speaking, their first feeding is a mash of meat, cabbage, and potato. To me, something like that would be a much better food than cereal or fruit or vegetables. So, but you're right, it's very hard to sell the American people on starting meat because we haven't done it for 10,000 years.
They talk about the overload of protein, not only about iron, the overload of protein that's present in meat in general.
Yes, but you have to have, you were talking about the energy, the food gap here. Once you get past 6 months, you have to have another source of protein. And there's no question that meat or other dairy products are the best source of protein.
Plant sources of cereals that are supplemented, or plant sources of animal, protein sources of animal source, this is very important. But the other concern of administering high protein related to allergy was disapproved. And excess protein, or giving protein that early of animal source, was not associated with increasing the risk of allergy. This was apparent. And giving cereals may not mean decreasing the protein load, and giving animal sources in a small amounts or calculated amounts may judge the way of giving the amount of protein to this infant. But these are something in use. It's not our usual habit in practice, but it's adopted in many countries and in many areas, and most of the research is evolving, are discussing with these areas.
Last question is, I don't ever see birds.
Welcome to Jordan.
What was you going to say?
Join the club.
Join the club.
Even we don't see it, but I'm saying about the vitamin D deficiency. Most of the studies we are performing for vitamin D level are becoming low. So when I have a low.
Yes, the answer to the question is you must take the supplements all the time.
As in case of treatment for deficiency.
For deficiency, defined as not rickets, but just a low 25-hydroxy-D level?
Yes.
You have to take it all the time. If you stop taking it, your levels will go down.
Is there a loading dose for
I don't think there's a loading dose necessarily for that. If you follow the IOM guidelines for children, 400 to 600, for the most part, people will get above 50 nanomoles per week. As soon as you stop taking that, just like if you measure 25-hydroxy-D
بنفس اللي
Northern
موجود في
hemisphere, probably
الجدول.
southern hemisphere as well, your level goes up in the summertime, goes down. No, but there's, you should take the vitamin D you really should take it all the time. And your question about the sun, absolutely, when the sun is at its peak height, that's the best time to get the vitamin D exposure. And if you're above, I think it's 35 degrees north latitude, which is somewhere across the southern United States, you can, after the month of September in the northern hemisphere, you can be out in the sunshine all day long. Nobody would do that because of the cold, but you don't make vitamin D. The angle of the sun is not good enough to make vitamin D in the skin. People have done this, exposing skin culture to the UVB rays. And above a certain latitude, around 35 degrees, after the month of September, after the fall solstice, at the end of September, you can be out all day, you won't make any vitamin D. Part of the problem is the concern about skin cancer. And you know, the American Academy of Pediatrics and the Dermatology Association, they recommend don't ever take children outside without sunscreen. Sunscreen, if used correctly, very effectively blocks the UV radiation. You won't make any vitamin D if you're using sunscreen as recommended. Ordinary window glass blocks the UVB radiation as well. So the dilemma is, okay, yes, you could get sun, but you're worried about skin cancer and use of sunscreens in children. So it's hard to recommend both sunshine and protection from cancer. It's a difficult question to deal with. But one of the points I wanted to make here, which really didn't come up about the breastfeeding, and the 4 versus 6 months. I saw Dr. Manella's name on several slides, Dr. Julie Manella. I don't know if she's ever been to the Middle East to speak. She works at the Manel Sensory Institute in Philadelphia, where they deal with the senses. And her specialty is the development of taste in breastfeeding babies. And she has absolutely amazing research showing, you know, what happens if you feed fruits before vegetables, vegetables before fruits, but even more importantly, she shows that what a mother eats during pregnancy and what she eats during lactation have a tremendous effect on the baby's acceptance of food, which is just fascinating. So if mothers eat more vegetables during pregnancy, if they eat more vegetables during lactation, it affects the baby's acceptance of vegetables. That didn't really come through here. That's a whole new area of research that's very exciting, which I think hopefully will help guide some of our guidance in making our complementary fooding guidelines. If we know how the baby's sense of taste developed and how important that is in the introduction of complementary foods.
Talking about the sun and when, actually it's enough for us to get the daily requirement of vitamin D from the sun if you are exposed for just 15 minutes, and this might be in the early time in the morning and before sunset. It's not during the daytime, at noontime, when the sun is very hot, and this might be because of this cancer. Number 2, it's not only the sun which you are deciding that you are getting enough, because those who are black colored, they are less benefiting of this sun. Those who are obese, and forgive me whoever is obese here, but the fat cells retain the vitamin D from being released to the circulation to get its effect. So the fatty the dark color will prevent, so you have to be exposed more than just 15 minutes. And for the treatment, as Professor Greer said yesterday, about how to diagnose a case of rickets just by X-ray. And again, how you know that it is improving and it is at its end by X-ray. You know what is healing, what is active, what is healing, and what is healed. So if you get a baby with the same bow legs and you feel that he's still ricketted, you have to do an X-ray. If the X-ray with this dark line at the end, you know that this is healed, so you can just leave him alone with the daily requirement you are just giving, but not heavy dose. And you are not afraid of toxicity, because again, as Professor Greer said, it is not that nightmare before everyone is coming to you, I'm afraid of giving an extra or mega dose of vitamin D. But just treat and follow treatment by clinical case as well and X-ray. If it is healed, you are enough for this. Thank you.
Thank you very much. I'm a neonatologist from University of Georgia. It's okay. My question to Professor Greer, if you have a case of rickets, you have case of reflux. So there was in 2007, 2008 in pediatrics a survey in 30 hospitals, United States and USA, and they mentioned that they are using Prokinetics 30% of their babies. I'm not aware now what is the situation after a new recommendation concerning Prokinetics. But the question about preterm infant neonates, there is no other choice than the H2 blockers, but as the other medication is not indicated in the first month. What is your advice and practice, please? And the other question, the second question about reflux in ultrasound diagnosis. We have a radiologist with interest in pediatric radiology, and he showed me when he gave that.
What's the definition? How do we define it? And how do we treat it? Personally, I don't ever use Prokinetics, period. Because I think they have adverse effects on the microbiome. And I'm not even sure I believe in reflux. You know, if you're a neonatologist, every time a baby has an apneic episode during a feeding, oh, that must be reflux. And then you try to diagnose it with a swallow study, it takes an enormous amount of radiation, and most babies seem to have some reflux when they do the swallow study. So I don't ever use Prokinetics. That doesn't mean that other people that I work with don't use them, but I personally don't believe in them. I think it has more adverse effects than positive effects, and I don't know of any randomized controlled trial on a newborn that showed that they're beneficial. But again, if you can't diagnose what reflux is, and it's hard to come up with a study that would. Yes, and when people do the studies of nurses' impressions of reflux, you know what those show, where they do, you know, the videos, where they put the probes down and do the videos, and the nurse is supposed to mark on the piece of paper when she thinks it has reflux. She's wrong all the time. She has no idea when there's reflux. So it's very disconcerting. The literature is very disconcerting on this. But nurses' opinion is not valuable in estimating reflux. Though every nurse will tell you this baby's got reflux. But when people look at the studies carefully, a nurse can't diagnose by expert opinion that the baby's having reflux.
I have another answer to the question you asked about the ultrasound diagnosis of reflux. This came from France, but studies on it published are not sufficient enough to consider its level of evidence, sensitivity and the specificity of this technique in the diagnosis of gastroesophageal reflux. Maximally, it will be like the pH-metry, but it will not exceed the pH-metry. The advantage is that it is non-invasive, but
actually refusal of feeding is one of the very important infantile problems, and Chatur, Professor Chatur, is one of the famous professors who worked in this area of eating disorders of infancy and early childhood. As you know, eating disorders of adolescents and adults are well studied. So she studied this and introduced the terminology of infantile anorexia. I refer you, Dr. Ahmed, to Chateau's textbook, and it's available on the web for free. Chapter of infantile anorexia is available, and when you read it, you'll find more behavioral ways of management of mothers more than infants themselves, and advices there cannot be mentioned in just an answer of a question, but this is a very good book and a very good chapter to read about. What is the most important faulty practice in nutrition feeding you face? Leading to anorexia.
I see a lot of bad habits. The mother came to me and told me I feed my kid with mashed potatoes, for example, rice and yogurt. This is very common. The rice and yogurt is very common because it's very easy to swallow, and the honey, which is very common because they said it's very natural. It's natural and it's safe. And I see the fruits, they begin with the fruits. So when they start with fruits and then they give the children or the kids, they give them after that the vegetable, they refuse to take the vegetable. So this is a very common problem. I told them to start with the vegetable and after that they can start and they can begin to with fruits.
So will you advise to add sweet or salt to the diet of an
You add any sugar, any salt? No, only lemon. Yeah, some lemon, no sugar, no salt, nothing. Only lemon, only natural lemon.
Neither pepper.
Neither pepper, no. Of course.
Another question, please. Here. Yes.
Regarding the vitamin D synthesis, as Madam mentioned earlier, in Middle East, if we screen for the vitamin D level, many of us will have a low level or insufficient level. But as Madam mentioned earlier, but if we expose to the sun in the early morning and late in the evening, the amount of ultraviolet radiation required for the vitamin D synthesis is very less. So it is recommended that in the middle of the day, we should expose to the sun for the adequate production of vitamin D. Another thing, we use this sun screening lotion many of the time. That also will block the ultraviolet radiation. So in that case also we cannot synthesize vitamin D adequately for our need. Is it correct or not?
Can I answer the area of sunblock? And this, I was exposed to this subject before, and it was found that there are 3 types of ultraviolet rays. The risky one is ultraviolet ray type A. Type B is the most important for conversion of 7-dehydrocholesterol into cholecalciferol under the skin, and it's now recommended to have the sunblock that can block A wavelength but not the B wavelength, so that if you are putting this sunblock of a special character, it will not deprive you from the ultraviolet ray type B that is essential for vitamin D synthesis.
The timing when we should expose to the sun for producing the maximum amount of vitamin D. As
yes.
Timing. Well, I would disagree with the early morning and the late afternoon. Because
we are back. We are going back home with the same confusion which we have been come with.
I mean, what the baby to eat, when the baby to eat. Additional complementary food should be only 1 feed or should be 3 feeds a day. Cereals should be gluten-free or not. Cereals is better than vegetables and the fruits. A baby who has been taking breast milk, should I give him on the spot meat and vegetables in the beginning rather than giving him something easier to digest in the beginning and then introduce other things? Is it 1 feed a day? Is it 3 feeds a day? And the other things actually about the vitamin D, if you allow me to comment. Vitamin D, it's very easy for the mother to give vitamin D additionals, but the questions which we are all faced as pediatricians, I'm taking my baby to the sun every day, and I expose him. We are going swimming, or we are going walking for about half an hour a day. Why should I give chemicals? Why should I give vitamin D? I'm exposing him more than 20 minutes a day. So what is the use of giving 1 ml of vitamin D, which the baby after which he's going to vomit? You know, the last point, if you allow me, I think it is on the first line. It is our duty and our responsibility towards our patient to be the first line of explanation regarding feeding, regarding eating, regarding medication. We are not just to prescribe medicine, because if we are to prescribe medicine, we should not be sitting in the meeting today, because nutrition and medicine is 2 different entities. So I think we should have the time for our patients. A patient comes, he pays money for the consultation. He has chosen X doctor because he knows that this X doctor is coming to give him the advice. So I cannot tell him, I don't have time, so go to other body to give you the nutritional advice. So I think we are dedicated to have time for our patient to give them. And before that, we should educate ourselves what we should tell our patients. Thank you very much.
Thank you for very marvelous comments for this meeting. Thank you. And we can consider your comment as a recommendation for physician to pay more time to learn the nutritional aspects and to convey this message to mothers while they are consulting him as a physician. Number 2, to be influential and focus of elimination in his area, not only as a physician who prescribes medicine, but a physician and a source of light who can enlighten the life of mothers. Regarding the, when I gave an example of the Egyptian guideline, you notice that I passed by it rapidly and I didn't give it because I don't mean to give the Egyptian example as an example. It's only an example that every place can provide his own guidelines, but he should know the differences from the international ones. Regarding the number of feeds, there was a table by the WHO, and this table was very clear to give 2 to 3 feeds between the age of 6 and 9. Then after that you give 3 to 4 feeds, and this is the recommendation that is accepted, and there is no differences that can be explained in different countries, so it's not feasible to give. But you are going to give one food, then you are trying the other food. As the WHO mentioned, it should be small amount, gradually increasing, then trying the other time, then trying the other time, then giving 2 to 3, increasing it to 3 to 4 after the age of 9 months. Which type of food to start? The recommendation is to start with iron replenishing food, whether the cereals that are well replenished by vitamins and minerals, especially iron, or if you have in this, you can give animal source of the protein, and both are alternative. The thing new here is that we were afraid from the animal meat that early, and the recommendations are now, it's not that harmful, it's not harmful at all, so you can think in it as alternative way of feeding with cereals. But starting with fruits, as we used to do, may not be of help. This is a recap of what was said in the recommendations, but I know you should have these materials with you. It can be translated according to the language in the country, patients coming to you. If it's in English, take it in English. If it's in Arabic, take it in Arabic. And we can spread this for mothers during their stay with us. and you can explain it for them. This will help a lot. Thank you.
I have just a comment regarding the vitamin D level. Like since many years now, around 10 years, we are checking the level of vitamin D for many healthy kids and adults, and almost it is low, below 30. And my comment, do we have to reconsider the normal value of vitamin D level, like 20 to 30, and in which basis they just put it below 30, it is deficient? That's my comment.
Well, there's just been a lot of discussion about this in the United States. You know, the adult medicine people believe very firmly the cutoff should be 75 nanomoles per liter. Personally, I'm going to go with the experts with the reform for the IOM, and they feel pretty strongly that if you have a serum level of 50 nanomoles per liter, you should be sufficient. That doesn't mean that for every person, 50 is the magic number. There's a lot of genetics involved here, which we don't know a lot about yet. So maybe 35 is fine for some people, they don't get rickets. But as a general rule for the population, I think I would stick with the 50 nanomoles per liter. I think it's a nice compromise between 30 and 75, if nothing else.
I have answer to you. One of our studies that are not published up till now, we found that persons having 32, 35, 30 something, when they were administered to vitamin D, their level was not changed, and this is their maximum level of achievement, and they didn't have any problems of vitamin D deficiency manifestations at all. So, excuse me, I think that 30 is okay for our countries. And you may recommend that is 30 okay, sometimes 28 may be normal person and is not insufficient, because insufficiency is defined differently from deficiency. So you may consider, according to rules, it is insufficiency. And you find that he is doing well, he is not rachitic, he is not having any other bone diseases, any other abnormalities. Can you agree with? I think 30 is okay for our countries.
Small question here.
Yes, another question.
Very small question.
Yes.
Now, okay? Now my patient is coming to me. She is weaning or she's having complementary food, and she cannot breastfeed, and she cannot afford to have milk, fortified milk. What can I tell her? Don't go for cow milk. Don't go for what she's going to have? Nothing. What is
the international recommendation is that there should be milk.
Okay.
This milk should be breast milk, and encourage continuation of breast milk for the age of 2 years. And if it is not available, you should have milk. Milk as unmodified cow's milk is never accepted before the age of 12 months. So if she came to you, there should be a way in the country to guarantee availability of milk between the age of 6 months and 12 months, in addition to the complementary feeding, for those who did not manage to continue breastfeeding. And after the age of 12 months, you are free to use whatever the type of milk is, even the unmodified cow's milk, according to the recommendation. But there should be a coverage of the interval between 6 months and the 12 months by a modified milk that is adaptable for the use at that age. We can come to the end, and Dr. Sabri can close this grand meeting. Thank you.